Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Many patients come to the clinic asking about some supplements or some antioxidants, and most of the infertility and even pregnant women are taking over-the-counter drugs aiming at improving their health and their fertility or pregnancy condition. One of these supplements is Inositol, and they are coming to you asking about the value of using this supplement during pregnancy, and you have to be aware about important two types of the inositol, which are myo-inositol or dichiro-inositol, and what's the difference and what is the concentration of the inositol inside this supplement. Is it allowed to use for fertility patients for pregnancy or not? You know that inositol is just sugar, and it was considered as a vitamin B8, as one of the members of vitamin B group, but this is a misnomer as it is not an essential nutrient, and it is formed from glucose. And 99% of inositol in the nature, it is myo-inositol isomer, while 1% only is dichiro-inositol. So the first message that the percentage in nature is towards myo-inositol, and dichiro is 1% only. So when you use any drug containing inositol, should contain a ratio which is more or less similar to nature. And it's found in fruits, vegetables, nuts, grains, dairy, and others. And each tissue has a different myo-inositol, dichiro-inositol ratio, specific for the function performed. The second message that the myo-inositol has different functions from dichiro-inositol, but together they have some conjoint or some concomitant functions. So the inositol group has some functions, but if you go in depth, the myo is different from dichiro, and the concentration of myo is much more higher than the dichiro, despite the variation in the different tissues of the body. As I told you, it is a sugar composed or formed by glucose changed to glucose 6-phosphate, and then myo-inositol 1-phosphate, which is transformed by dephosphorylation into free myo-inositol. And the free myo-inositol now in the systole is changed into two issues. One is dichiro-inositol. So dichiro is an outproduct of the myo-inositol under the effect of epimerase enzyme, and this is an important enzyme. And this epimerase enzyme is dependent on insulin. So insulin is important. Epimerase enzyme is important to form this minimal amount of dichiro-inositol in the systole. At the same time, both myo-inositol and dichiro-inositol will change into a derivative, which is called inositol phosphoglycan. And this inositol phosphoglycan is the active form of the myo and dichiro, and it acts as an intracellular second messenger in different cell systems. So the activity actually comes from the derivative of myo and dichiro, by releasing of this second messenger into different cells. And the glycan derivatives, either inositol phosphoglycan A or P, will regulate several metabolic and endocrinologic pathways of the body. So the dichiro is a product of myo under the effect of insulin-dependent epimerase, don't forget. Okay, they are working as second messenger. Second messenger, what does it mean? That they are mimicking some hormones of the body. The most important hormone and the most famous hormone that they are mimicking it is insulin. So they have an insulin sensitizing character or mimicking character. And this can lead to rapidly decreased peripheral hyperinsulinemia. And this is important. The inositol phosphoglycan also, which is a derivative of both myo and dichiro, work as a messenger of TSH, regulating the activity and replication of the thyrocysts. And this is important in some studies in cases of subclinical hypothyroidism during pregnancy, autoimmune thyroiditis, Hashimoto, or even in some cases of thyroid cancers, and these have been used in or studied in many publications. The same derivative of myo and dichiro is important as a brain chemical, dopamine and serotonin, so it can be used to treat some cases of hyperprolactinemia in addition to its main work, but little studies are found on this topic. And the most important issue in the second messenger function of the derivative of myo-inositol is FSH signaling. FSH signaling means it is a second messenger of FSH hormone. And this will lead to improving ovulatory functions, helping oocyte maturation and embryo development, improving oocyte quality, and obstetric outcome from IVF-XC. So these are the functions of the myo-inositol and dichiro-inositol. Dichiro is sharing the myo-inositol in the insulin sensitizing or insulin mimicking functions, and many studies on the myo-inositol regarding it as an FSH signaling second messenger, TSH, and some brain biochemicals like dopamine and serotonin. We have to know that myo-inositol modulates FSH-mediated AMH production, and this will help oocyte maturation as well. What about insulin mimicking function? We have to know it in details. Insulin sensitizing character or function and insulin mimicking function of both myo and dichiro are important. Why? Because myo-inositol promotes absorption of glucose from the blood, leads to hypoglycemia. And by this way, it can control diabetes by taking glucose from the blood to the cells. So it helps glucose catabolism. On the other hand, the dichiro promotes synthesis of glycogen, changing glucose to glycogen, and this leads to decrease blood glucose as well. And this is glycogen synthesis helping or function of the dichiro. So the myo helps glucose catabolism and the dichiro glycogen synthesis. So they work by two different mechanisms, but the ultimate function is insulin mimicking character and minimizing hyperglycemia and hyperinsulinemia as well. So dichiro modulates insulin secretion, improving insulin sensitivity, the mitochondrial respiratory chain, and glycogen storage. So the total function of the both as working as a secondary messenger in the insulin signaling pathway that they lead to decreased glycemic level, decreased hyperinsulinemia, and inositol, particularly inositol, buffering negative effect of sustained insulin stimulation upon the adipose tissue and endocrine system. So you told me that they are insulin mimicking drugs or substances. So the question now, can we use myo-inositol or inostols generally to treat diabetes because they are decreasing serum glucose, hyperinsulinemia? So this is a good function. They are insulin sensitizers. Can we use them for treatment of diabetes? Yes. Both Mayo and the Dicairo showed insulin mimicking character in conditions of insulin resistance. And one of the studies found that this myoinositol and dikairoinositol combination can be used as a possible alternative to metformin or other insulin sensitizing drugs, even in males with little side effects, particularly in patients with metformin intolerance or drug contraindications. So this is another message from studying the physiology and the mechanism of action of these drugs that they can be used to treat diabetes. So the second point, what about the ovary? You are talking about diabetes. Okay, this is a systemic problem in the blood. What about the ovary itself? In the ovary, we have to know that we should go in depth to know the exact function of the myo and the chiro. In the ovary, the myo and the chiro have specific duties. Myo supports FSH signaling as a second messenger of FSH, while D-chiro is responsible for insulin-mediated hyperandrogenism. So the chiro increases androgens, while myo increases estrogen. So in the ovaries, they have different functions. We have to know this. So if you have a patient seeking fertility, for example, or menstrual abnormalities, and you give her high dose D-chiro, you will increase androgens. And these androgens are insulin-mediated androgen secretion, testosterone, and dehydroepiandrosterone. And this way, this will lead to decreased estrogen, and you will harm your patient by this way. So in the normal ovary, there is balance between myo and the chiro. And as I told you, myo should be much more in amount than the chiro, as in nature, 99% in nature is myo and 1% is the chiro. By this balance, there is maintenance of the normal hormonal level and facilitating ovarian functions. This is in normal ovary, okay? So in conclusion of this point, that in the normal ovary, we need the chiro to stimulate minimal amount secretion of androgens. And this minimal amount of androgen is important for formation of estrogen under the effect of aromatase enzyme. But the main function or the main amount of inositol in the ovary should be myoinositol. Why? It supports FSH signaling, improving quality of the eggs, and so on. So this is in normal condition. But what about polycystic ovarian disease? This story is different. Why? Because in PCOS, there is accumulation of a good amount of D-chiro-inositol more than the normal ovary, 4 times more than the normal ovary. Why? Because there is accentuated epimerase activity, which is insulin dependent. So accentuated insulin dependent epimerization of myo to the chiro-inositol. By this way, there will be a higher D-chiro myoinositol ratio, and this will promote hyperandrogenism and reduces the efficacy of myo-mediated FSH signaling. So we have to differentiate between 2 types of patients: patients with normal ovary and patients with polycystic ovary. Normal ovary balance between myo and D-chiro, minimal amount of D-chiro, and epimerization is in normal condition. But in PCO, epimerization is accentuated. Why accentuated? Due to systemic insulin resistance and hyperinsulinemia, and it will be 4 times more than normal. So there will be high D-chiro myoinositol ratio, and this promotes excessive androgen and minimal estrogen production. So it is so serious in the ovary to know this fact. So we have 2 opposite functions exerted by the myo and the chiro in the ovary. Only the myo acts as a secondary messenger for FSH. So if there is increased myoinositol, this will enhance aromatase sensitivity, activity, estrogen production, promotes FSH activity, decrease androgen senses. While if the D-chiro increases, this will lead to aromatase inhibition, increase androgen, and this is the reverse of the function of myo in the ovary, and this is called inositol balance. So myo is responsible for increased glucose uptake. Okay, this is important for decreasing hyperglycemia, FSH signaling, which is peculiar to myo, and aromatase stimulant. D-chiro is insulin-mediated androgen production and aromatase inhibitor. And this figure shows you not to forget that a high concentration of myo is required to ensure healthy oocyte maturation in the ovary. Only myo can stimulate FSH to go to granulosa cell to form estrogen. But D-chiro inhibits aromatase activity, stimulates androgen formation. So the end result of excessive D-chiro is excessive androgens and decreased estrogen, and this is not good for females. Both insulin and D-chiro stimulate testosterone production. So insulin-mediated D-chiro function or insulin direct on the theca cell or the D-chiro and the theca cell will work. So there are different mechanisms of increased androgen production by D-chiro, which is insulin-mediated, and insulin is important for epimerization. What about this in the ovary? What about the other organs of the body? We have main organs of insulin, which are adipose tissue, liver, and muscles. There are different ratios of the inositol isomers, myo and D-chiro. In the setting of, in these tissues, the reverse of the ovary, there is a relatively high proportion of D-chiro is required in the functions of these organs. So in the liver, muscle, and adipose, D-chiro is more than myo, while in the ovary, myo is more than D-chiro, as I told you. And if there is epimerase deficiency in these tissues, so less myo can be converted to D-chiro because no enzyme. And this will lead to D-chiro inositol deficiency in these tissues. And insulin resistance is promoted. And this will lead to metabolic complications of hyperinsulinemia. So this is the mechanism of insulin resistance formation because of the insulin target tissues may have some setting of epimerase deficiency and decreased D-chiro production, and this will lead to insulin resistance and metabolic complications of hyperinsulinemia. This is different from the ovary because the ovary is in cases of epimerase deficiency. The ovary remains sensitive to the effect of insulin as it is immune to insulin resistance. So hyperinsulinemia alters FSH production and LH shift, preventing selection of the dominant molecule. Insulin also increases granulosa cell sensitivity to LH, increasing ovarian androgen production. Insulin activates mitogenic pathway in the ovarian cells. By this way, it will lead to increased transcription of steroidogenic acute regulatory proteins, and this will lead to increased androgen production. The end result will be hyperandrogenemia, and this will worsen insulin resistance. And this is called ovary paradox. What does it mean? The ovary is different from the insulin target tissues, liver, muscle, and adipose tissue. In cases of epimerase deficiency, there will be insulin resistance because of decreased D-chiro. But in the ovary, there will be continuous change into D-chiro, and this will lead to hyperandrogenemia because of continuous epimerization, as the ovary is sensitive to the effect of insulin and immune to insulin resistance. And this is called ovary paradox, different from the insulin target tissues. If we go to polycystic ovarian disease mechanism, we will see that the recent studies found that insulin resistance and hyperinsulinemia is the main problem of PCO patients. And due to hyperinsulinemia and insulin resistance, there will be an hyperandrogenism. And all these items can be improved by giving the patient myo-inositol. It will improve insulin sensitivity and decrease hyperinsulinemia. It will decrease hyperandrogenism by indirect increasing sex hormone binding globulin and subsequently decreasing testosterone, or directly by affecting the androgen production in the ovary. It will improve cycle control by increased FSH signaling as a secondary messenger. This slide is so important. You can see here the serum, and you will find the myo-inositol, the Cairo-inositol ratio is 40 to 1. 40 to 1 myo to dicairo. In the theca cell, the ratio is 20 to 1. In the granulosa, 60 to 1. In the follicular fluid, 100 to 1. What is the message of this ratio distribution from this excellent study? The message that in the follicle, here is the mature, the oocyte, the high concentration of myo-inositol is important to complete development and maturation of the oocyte because the percentage is 100. And also myo is important for the functions of the ovary and the female by high ratio 40 to 1. In the theca, it is 20 to 1 because of frequent epimerization of myo to dicairo that forms testosterone, and testosterone goes to granulosa to help estrogen. But if it is in a minimal amount, if it is excessive amount, this will lead to hyperandrogenemia. And due to the effect of myo on the granulosa cell via increased intracellular calcium oscillation, there is increase anti-Mullerian hormone production and increase ovarian maturity. This can be done via the phospho-inositol diphosphate enzyme. So these activities actually are mediated by insulin in the ovary. The effect of myo and dicairo are insulin dependent, and this is an important figure. So we understand now that myo is essential for folliculogenesis and maturation of the oocytes, while dicairo, minimal amount is needed to increase secretion of testosterone, which is needed to estrogen production. So in normal situation, we have to give 40 to 1 ratio as in serum. So myo enhances FSH and estrogen responsiveness, strengthening the aromatase and FSH receptor expression, while dicairo is insulin sensitizing effect, and it may help in testosterone formation, which is a precursor to estrogen formation by the granulosa cell. What happens if you give dicairo alone? This is not good at all because it stimulates androgen, senses testosterone and dehydroepiandrosterone, and decreases ovarian estrogen pathway. This is not good for an infertility patient or a patient or a female in the reproductive age. So dicairo inositol supplementation alone is not recommended at all for females because of high dose dicairo per day have been considered toxic to the ovary and oocyte maturation, as it is aromatase inhibitor and increases androgen. And this would lead to harmful consequences for the ladies. Also, it is not converted to myo because myo to cairo conversion is a monodirection, under the effect of insulin-dependent epimerase enzyme. Myo and myo derivatives are correlated with many insulin resistance conditions. So don't give for a female dicairo alone. It is not recommended. Moreover, the intestinal absorption in some studies found that intestinal absorption of mayo is reduced by simultaneous administration of dicairo, since the two stero isomers compete for the same receptors or same transporter that has a similar affinity to each of them. So if you give a good amount of dicairo, this will prevent absorption of mayo in those cases. So all these contributing factors for minimizing the dose of dicairo if you are dealing with a female. As I told you, in PCOS, the story is different from the normal ovary because PCOS sensitize dicairo 4 times more than measured in the controlled theca cell. And here you can see in this figure that the mayo production in PCOS is decreased and dicairo increase in the insulin production of these substances in the ovary, granulosa and theca. And this will lead to decrease aromatase activity, increase androgen testosterone dehydroepiandro, and this is deleterious for the functions of the steroidogenesis and production of the oocytes at the same time. And this can explain why treatment strategies based on high dicairo have been recognized as poorly effective, as dicairo promotes androgen synthesis in the theca and downregulates aromatase and estrogen expression in the granulosa. So now it is clear that mayo is important for ovarian functions. If you give dicairo, it should be minimal amount, 40 to 1, very minimal dose. Don't give more than this. And if you have a patient coming to you with a supplement with Inositol, you have to look to the dose. If the mayo is higher than the dicairo, 40 to 1, this is more or less physiologic and effective. And this slide summarizes that mayo is converted to dicairo under the effect of insulin-mediated epimerase enzyme. And this will improve insulin sensitivity by allowing glucose to go inside the cell, glucose catabolism, and the dicairo stimulates glycogen. This controls glucohyperglycemia by changing glucose to glycogen, and also regulates ovarian steroidogenesis by increasing androgen in a minimal amount if given. In the ovary, the mayo mediates the granulosa response to FSH and has a crucial role in determining oocyte maturity. So the oocyte quality is improved by mayo due to intracellular calcium oscillation, and this is essential. So decreased dose of SH in PCO and non-PCO will lead to improvement of oocyte quality and increased rate of successful pregnancy. If the increased dose of dicairo, as I told you. Because high dose of dicairo has a deleterious effect on oocyte quality and aromatase inhibitor. These are important physiologic and pathophysiologic functions of mayo and dicairo in normal ovaries, in PCO patients, and in insulin target organs versus ovary, as you already seen. But what about publications? New preclinical and clinical studies support the importance of administration of combination of mayo dicairo in 40 to 1 ratio, which is the physiologic ratio in the blood. Many publications support this concept, and mayo significantly improves the hormonal and metabolic profiles of patients of polycystic ovary and significantly impacts the clinical development because it improves insulin resistance, which is one of the main causes of pathology or pathophysiology of PCOS. So if you give Inositol 1 gram twice daily for 6 months, this will lead to improved hormonal profile and decreased serum insulin as seen in this study. As I told you, this figure is excellent, and actually it is published in a study on PCOS, and Inositol in the dose of 4 grams per day, 2 grams twice daily, 3 months prior to ovulation stimulation, is effective in normalizing ovarian functions, improving oocyte and embryo quality in case of IVF-XC. If you compare Inositol with metformin, it is well correlated with more or less no side effects, while metformin has reduced patient compliance due to GIT symptoms, nausea, abdominal pain, and diarrhea. And the results in 26 randomized controlled trials of using Inositol is not inferior to the metformin. And 9 randomized controlled studies found that Inositol alone or combined with Decairo in the normal 40:1 ratio improves the metabolic profile and also increasing sex hormone binding globulin, decreasing testosterone, and decreasing hyperandrogenemia for at least 24 weeks in this study. Another study compared different concentrations and found that 40:1 is the best concentration to achieve improvement or success of this combination. And a narrative review found that there is enough rationale to further study ratio of other concentrations. As I told you, in the follicular fluid, it is 100 to 1. Why not to test this concentration to make the Cairo as low as possible? And the Cochrane library found very low quality studies despite the study of 13 trials. And this is a recent meta-analysis of the publications on Inositol in infertility and IVF-XC. Some studies found no improvement, some found improved clinical pregnancy rate, some found it's effective in normalizing ovarian function, improving oocyte and embryo quality. Others found no difference, others found improvement to oocyte quality, blastocyst development, and clinical pregnancy rate, and others found higher fertilization rate. And if you look to the most of these studies are focusing on the PCOS. And if you look to doses, you will find different doses. 1.2 to 4 grams per day, 4 grams per day, 1.2, 4 grams per day, 4 grams per day, 400 microgram folic acid combination, 2 grams per day, and so there is variation in the dosing and the duration, 3 months, 6 months, and so on. And this is the main cause of non-draining sharp conclusions regarding the efficacy of the drug during infertility or IVF-XC, because the study is different in different parameters, including dosing, duration, combination, and the ratio of Mayo to Cairo, and so on. And here is an example of 30 trials found that benefits of Mayo de Cairo for some metabolic measures and potential benefits from de Cairo for ovulation, but Inositol may have no effect on other outcomes, and these studies prove is limited or inconclusive. And the clinicians and the patients should sit together and discuss these evidence-based studies and the postulated mechanisms of action and benefits, and to explain to the patients that the studies are not are inconclusive or of limited importance, significance, because of the variation of the different studies in combination with other drugs and different ratios and different methods and different patients, and all these factors contribute to the heterogeneity of the results. What about the treatment duration? Some studies found that if you have to give it Inositol for 3 months, if you are preparing a patient for IVF-XC, 4 grams per day. Some studies found to achieve control of hyperandrogenism to give it for 6 months, like anti-androgen drugs. Some studies mention that we have to give some drugs to enhance absorption of the Inositol at the level of the intestine, and many studies on the alpha-lactalbumin combination to enhance absorption at the level of intestine, as published in many publications. As we mentioned that Inositol mainly and the trivial amount of Decairo act as second messenger of insulin, of FSH, of TSH, and some brain matters or materials some brain compounds like serotonin and dopamine. So can we use the Inositol? We answered one question. It can be used to treat diabetes. Here in this review, it can be used to treat the type 1 and type 2 and pre-diabetics also, and insulin resistance. It can treat metabolic syndrome, which is increased glucose, increased insulin, and increased waist circumference, and increased triglycerides, and decreased high density lipoprotein. Also, it can be used to treat PCO and patients with or without risk of gestational diabetes. Some studies on gestational diabetes found that if the patient is using 4 grams per day during pregnancy, significantly improvement of glucose tolerance and decreased incidence of gestational diabetes by up to 80% of some other studies. And evidence from 7 studies showed that antenatal dietary supplementation with mayo during pregnancy may decrease incidence of gestational diabetes, hypertensive disease, pregnancy, and preterm labor. However, the studies, as I told you, small studies, heterogeneous studies, different doses, different combinations, frequency and timing of administration, different ratio, long-term follow-up, adverse effects, lack of generalizability to other settings make the studies are not conclusive. But you have to put in mind the physiologic and pathophysiologic functions of Inositols. Mayo is different from Inositol, as I told you. The metabolic syndrome already mentioned in postmenopausal women with metabolic syndrome, 2 grams of mayo twice daily for 1 year will significantly decrease HOMA-IR index by 78% compared to group of placebo under the treatment with diet only. It can be used for males to increase sensitivity of insulin, and some studies found it's important for maturation of spermatozoa and even motility, but these are limited studies. In conclusion, I would say that due to the insufficient understanding of the etiology and its heterogeneous nature, the treatment of PCOS remains symptom-oriented, and many doctors are treating infertility by induction ovulation, menstrual irregularities by COCs or other hormonal profile, androgen by anti-androgen drugs, and so on. And this is called symptom-oriented treatment. We have to change this concept to be patient-tailored or patient-oriented concept, and should be etiology and mechanism-based rather than treating symptoms of PCOS. Mayo and Decairo are 2 stereoisomers of Inositol, and these natural molecules are safe, well tolerated in therapeutic doses. If you give more than 4 grams every day, this can lead to some side effects, and they have insulin sensitizing activity. And this is crucial for insulin resistance, particularly in patients of PCOS. In addition, mayo Inositol mediates FSH signaling for women with PCOS. There may be a benefit of using mayo, although again, the dose regimen is unclear. And mayo is treating patients because it is a novel method to ameliorate PCOS symptoms, improve spontaneous ovulation, and induce ovulation, improves follicular development, cycle control, correction of pre-diabetic state, and insulin resistance, correction of hyperandrogenemia. So it is a new concept of management of PCOS, and altered physiologic Inositol ratio may account to pathologic conditions causing an imbalance in sex hormone. As I told you, 40-1. Don't exceed this, don't minimize this ratio towards the side of Decairo. By this way, this will block the aromatase activity, will decrease estrogen, will increase androgen, and lead to hyperandrogenemia, which is insulin dependent, and this will lead to insulin resistance. The current lines of therapy of PCOS focus on a single aspect of PCOS pathophysiology, and none is able to address all clinical aspects of the syndrome. Combination Inositol therapy has the potential to improve all symptoms, signs, and laboratory anomalies of the PCOS. Both Inostols If they are given together, 40 to 1 should be able to improve the required concentrations in both systemic circulation and ovary, thus addressing ovary install paradox. The correction of the systemic install resistance by Mayo will treat the metabolic features of PCOS, and simultaneously adequate decairo will help creation of a healthy intra-ovarian milieu, which will correct hyperandrogenism, improve menstrual irregularities, and promote ovulation and fertility. Thank you.